Good day everyone. Me, Bao Yi, together with my members, will present a case of meningitis. This case is about a 65 years old male who is allergic to penicillin. He complains with neck stiffness and fever for 7 days. He also has smoked for the past 15 years. For the history of presenting illness, he had experienced fever and headache, which associated with inability to tolerate loud noises and bright light. He also lost 7 kg over the past few months and was admitted to hospital 2 weeks ago due to poor blood sugar control. For the past medical problems, the patient had diabetes mellitus for 5 years, mild hypertension, bronchitis, appendicitis, hemorrhoid, fractured femur and splenic injury. And for the medications, the patient is currently taking metformin, glibenclamide, metoprolol, and theophylline. Moving on to the possible drug-related problems, the patient has uncontrolled blood sugar level and blood pressure. Thus, adherence and appropriateness of antidiabetic and antihypertensive should be reassessed. Besides, there is an interaction between metoprolol and theophylline. Concomitant use can cause metoprolol less effective and increase theophylline levels. Thus, signs of theophylline toxicity should be closely monitored. Apart from that, concomitant use of metoprolol and antidiabetic can increase the risk of hypoglycemia. Dose adjustment for metformin is required as the patient has impaired renal function.
I am Nabil. I will present the current and possible diagnosis. This patient has meningitis, mild hypertension, diabetes mellitus, and renal impairment. The evidence for meningitis in this patient is the symptoms: having fever, headache, associated with inability to tolerate noise and bright light, and neck stiffness. The lab result from lumbar puncture sample shows elevated white blood cell 600 per microliter, increased lactate level, decreased glucose level, and increased protein level. The full blood count shows higher white blood cells, and then CT scan of brain shows mild ventriculomegaly and sulcal effacement. Lastly, the neck reveals large, non-tender hard lymph node in the right supraclavicular fossa. This patient has high BP, which shows mild hypertension. The RBS of the higher RBS shows diabetes mellitus, and higher urea and serum creatinine shows renal impairment.
Hi, I'm DINI. Now I will present the recommended treatment for meningitis. As patient culture and sensitivity are available, we need to proceed for empirical therapy because delay in treatment can cause significant morbidity and mortality towards patient. Both HUKM and National Guideline preferred IV ceftriaxone 2 gram for every 12 hours or IV ceftriaxone 1 gram every 6 hours as first-line therapy of antibiotic. In addition of IV dexamethasone of 0.15 mg per kg every 6 hours and 10 mg for every 6 hours respectively. The alternative treatment for antibiotics suggested by HUKM guidelines only include IV meropenem 2 gram every 8 hours, while National Guideline has an additional suggestion on IV chloramphenicol 1 gram every 6 hours. Based on rationality, we decided to suggest IV ceftriaxone 2 gram every 12 hours plus 10 mg IV of dexamethasone and 1000 mg oral paracetamol for every 6 hours towards this patient. We decided to proceed with ceftriaxone antibiotic in this patient because first, the lumbar puncture results suggesting patient have bacterial meningitis. Second, the cross-reactivity between penicillin allergic patient and third generation cephalosporin are low, rare and negligible. Besides, no evidence suggests risk of anaphylaxis to cephalosporin in penicillin allergic patient. Furthermore, we choose ceftriaxone over cefotaxime because it has advantage of being administered as a single daily dose. Besides, ceftriaxone has broad-spectrum bactericidal activity against gram-positive and gram-negative bacteria and well penetrating into the cerebrospinal fluid and able to reach the therapeutic concentration in central nervous system. Besides, the common organisms that can cause meningitis are highly sensitive towards ceftriaxone. Next, we use dexamethasone as adjunctive therapy to to blunting the inflammatory response in CNS. Lastly, we use paracetamol for symptomatic relief or resolve the fever.
I'm Nadhirah. Next, I will present on the pharmacist intervention. The first one is by giving alternative treatment to treat patient's meningitis if patient shows allergic reaction to ceftriaxone since patient have allergy to penicillin. Next, de-escalation therapy, which involves conversion of broad-spectrum antimicrobial therapy to narrower antimicrobials once the result from CNS test is achieved. Patients' adherence to the medication also need to be reassessed since patients still have high self-monitored blood glucose despite receiving tablet metformin and glibenclamide, and patients also have slightly hypertension although receive tablet metoprolol. Pharmacists also can refer to nutritionists and dietitians to discuss on patient's diet plan due to patient lost 7 kg over the past few months. Patient's heart condition need to be assessed and provide appropriate treatment since patients have showed signs of heart failure such as finger clubbing. Lastly, pharmacists can encourage the patient to quit smoking by include patient in the smoking cessation program because patients still smoke at least 3 packs per day even though patients have other comorbidities such as mild hypertension, bronchitis, and diabetes mellitus. The last part is monitoring parameters. For efficacy, we need to monitor signs and symptoms of infection, WBC count, rapid culture and sensitivity test, monitor patient's blood pressure and heart condition as well as monitor patient's blood glucose level. For safety, we need to monitor any adverse effects of ceftriaxone, monitor patient's renal profile such as serum creatinine and urea, and monitor signs and symptoms of hypoglycemia.